retrieve those files, as well as the theater and the ward. So our study population was consecutive patients who underwent initial TURBT at the Kenyatta National Hospital between December of 2019 and December of 2020. That was the COVID year. And we included all patients who underwent initial TURBT between the study period and excluded any patient who was on surveillance who did not undergo initial TURBT at that period. And the number of patients that we got was 65. The male gender was 74%, with a ratio of 3:1. And significantly is that the patients who had muscle invasion, out of the 65, were 55% patient had muscle invasive bladder cancer on initial histology, and non-muscle invasion at 44%. Remember, worldwide non-muscle invasive account for 3/4 of the patient, but our patient more than half had muscle invasion. Now, treatment that was offered for this patient, 68% of our patient had no other treatment offered apart from the resection that was done. On paper, you would see that in up to 32% of patients. Maybe we can say the pathologist never looked at all the specimen, or our specimen really did not have muscle. So what is the recommendation? Is it time we started a hematuria clinic just for these patients? Should we have an equipped minor theater where we can do surveillance cystoscopy? We have a minor theater that has a flexible cystoscope, can just go in, scope, and if it is a solitary tumor, resect it. And maybe just like we did stents, we probably need to have a surveillance cystoscopy register. Perhaps we can have it electronic so that if a patient needs surveillance in 3 months, we get a reminder in 2 weeks. Then we call the patients so that we are not losing all these patients. Of course, we are limited by the small data, and our study had statistical heterogeneity. So in conclusion, RTUR uptake is poor, and therefore significant oncological outcomes could not be made. Histology reportage time does not affect the uptake of RTUR, and there is a prolonged duration between initial resection and first surveillance cystoscopy. Hematuria clinic, equipped minor theater, and improved theater booking may improve outcomes in bladder cancer, and a larger prospective study is needed to get more accurate results. Thank you very much.
Thank you, Dr. Muigai, for observing time. That was very, very good. So we go on with our presentations.
Yes, our next speaker is Dr. Joki Jiraine. She is a radiation oncologist at KU Referral Hospital, and she's going to talk to us on chemoradiotherapy for T3, T4 urothelial carcinoma of the bladder. It's just continuing on this bladder cancer. Karibu, Daktari.
So can I open the presentation first before you me, right? 1 minute, sorry.
How do you open it?
Yeah, I see. No, it's not that one. Just scroll down. No? post-2021 chemotherapy. Yeah, that one. My apologies for that. Thank you for the organizers of the conference for inviting me for this. And in the next 10 or 12 minutes, we'll go through chemoradiotherapy for T3, T4 bladder tumors. I have nothing to disclose apart from that I'm a friend to the Euros. So the outline will be a brief introduction. What are the challenges that we face, especially for patient or technical? What is the evidence that advises what we do for T3, T4 tumors? What's our current situation, and maybe have a forward plan from this. So as a way of introduction, we know that the management of bladder tumor, I think the cornerstone is a urologist. And I cannot understate the value of a TURBT and a histology. And as highlighted by the previous speaker, then issues like, is there muscle in the histology specimen that you've received? That, of course, informs what you need to do. And then the rationale for staging, because you need to assess two things. What is a local disease? That is based on the TURBT. Local imaging with MRI, and then need to assess for metastatic disease. And this could be in the local area, the nodes, and whether you have metastatic disease to visceral areas. And then the value of the MDT in decision making, because what happens is you get patients getting repeated TURBTs, and nobody ever sat down to interrogate, was there muscle involvement, was there nodal involvement before that. And we know there is value in bladder conservation protocols. So the days where you'd want to go and do a cystectomy, then the morbidity associated with that surgery is quite high. So we'd like to conserve this bladder for as long as possible. And what are the challenges that we currently face? For the patient, we know that our patients have advanced age. They will come with significant comorbidities. They've been smoking, they have COPD, they might have hypertension, cardiac issues, and all this need to be taken into account because of the treatment that you need to give. What are the symptoms that your patient has? So a patient with gross hematuria, even though we start discussing about what are the treatment options, we need to address the hematuria, and that's based on the TURBT that you'll do. And then for many patients who will present, they will have a late presentation, so they will come with the whole bladder full of tumors. I've never participated in a cystectomy, but I can imagine how bloody it is as you're trying to resect this tumor that is constantly bleeding. And then some of the patients will already come with preconceived ideas on what choice of treatment they want. I do not want surgery. I heard you can give me radiotherapy. Is there chemotherapy for my disease? Then the technical aspects which then involve us, the medical team, include what is the quality of that TURBT. And the quality here, I want to qualify the intra-op notes. Where do we document that this lesion is sitting? How much did you resect? Then correlation of that with the histology, because the person who makes or breaks you is a pathologist. So if we are still going in the era of sampling the tissue that the urologist gives us, then we end up missing muscle that was present, and then we think the patient had non-muscle invasive bladder cancer, well, they actually had muscle invasive bladder cancer. Then the radiologist, because there's an armamentarium of staging tests that you can do, but if your urologist is not keen or is not part of that team to discuss, was there invasion of the muscle? Are the nodes involved? Do we need to ratify how we are scanning our patients in terms of assessing of the nodes, assessing of the liver? Then, of course, I will put oncologist, but I will not complete that because I think the value is within the MDT, because also the rehabilitation of these patients post whatever treatment you are going to give is very important. And then resources have to always be at the back of our mind. It's not that we can afford to do everything, but what can we do that is judicious with the resources that we have? And finally, I think there is a delay, especially with our referral system, such that if someone is seen in a far-flung place where there is no urologist, how do they get referred to the urologist? So we manage them for recurrent UTIs until the patient presents with gross hematuria, and that's when the patient is able to come to us. So we know that for patients who have muscle invasive bladder cancer, if we leave them untreated, 85% of them will die within 2 years. And this is because one of renal compromise or metastatic disease. So then if we think about these patients who have T3, T4 tumors, or earlier from, let's say, T2 to T3A, we can think of radical cystectomy with urinary reconstruction. That is a major procedure. I will not speak to the urologist about that surgery. But then we have to think about the bladder conservation protocols, and if these patients relapse or progress, they then get into radical cystectomy. But the two options, there was no difference in overall survival, cause-specific survival, or distance recurrence-free survival. And that's important when you're counseling a patient who does not want surgery or wants surgery in terms of preserving their bladder if you decide to go for the bladder preservation protocol. I put in the next slide just as a reminder that for patients who are getting neoadjuvant chemotherapy, there were two big trials that were done, the SWOG and the UK EORTC trial. And there was, of course, a reduction in distant metastasis. The 10-year survival benefit, as we were talking about, improved, and the 3-year survival also improved. But we can discuss about the 6%, whether that's a marginal improvement or not, but there was improvement in that overall survival and disease-free survival. Then for the patients who actually got cystectomy, then what was the role of adjuvant radiotherapy? Vibrant data in this setting is not there, and we may have to risk stratify our patients, especially the ones who have high risk of local-regional relapse. Remember that for these patients, most of them, their risk is local recurrence, and especially dictated by the fact if you have positive surgical margins, especially for the patients who have a partial cystectomy, or if you have tumor spillage. Again, we have no benefit of addition of chemotherapy in these patients, and the dose is much lower than we routinely will give. So you will give, and you will cover both the residual bladder and wherever you made the incision, because that's an area of tumor tracking, and you can actually have recurrence there. So you would give to that area about 45 gray, with or without concurrent chemotherapy. I know for people who you find there's a positive margin, they would want to add chemotherapy, but the benefit is actually quite minimal. And then we cone down that field to the bladder to a total dose of about 56 gray. Now, if we're to think about which factors would inform us about the favorable effect of local radiotherapy, would be patients for early clinical stage, which is T2 and T3s. If you do not have ureteral obstruction, if you have a visibly complete TURBT, and this, we have to get it from your intra-op findings, because if you do not document you did a near total or a complete, then that also has an impact in terms of local control. And of course, patients with smaller tumors that are papillary or sessile without coexisting carcinoma in situ. And the person who will report for you whether there's carcinoma in situ will be your cystoscopy and your pathologist who will help with that. So if you are to get the model candidate for chemoradiotherapy, it would be the patient who has a T2 or T3 tumors, and that is unifocal. Tumor size of less than 5 centimeters, no carcinoma in situ, you do not have ureteral obstruction or hydronephrosis, the bladder has very good capacity, you have a visibly complete TURBT, and you have adequate renal function. I can tell you that for the patients who've given chemo-RT, most of them only meet 1 or 2 of these criteria. So you do not get this ideal patient, because then to go through the whole treatment, this can become an issue. Now, if we think as a radiation oncologist where the dose we are delivering, so the image on the bottom, you'll see the nice green and red. That's what we want to see in terms of dose distribution, because you want to make sure that you're covering the entire bladder, the nodes within the pelvis. I'll point out that, as we know, the bladder is a versatile organ. So depending on how much you filled the bladder, that will determine the position of the bladder in relation to where you are in the pelvis. The better we are getting at radiotherapy with things like IMRT, IGRT, or adaptive radiotherapy is to make sure that we do not miss the target, which is the bladder. So the protocol usually for radiotherapy is you come, the patient voids, they drink about 200 ml of water, they wait about 20 to 30 minutes so that you have what is a comfortably full bladder. Because you also don't want to treat the bladder when it's completely collapsed. It's deep within the pelvis, and that will push the dose to the dose-limiting organs, which is the rectum, which sits behind. So that's for the phase 1, which usually goes to about 46 gray. And then the second phase, we turn the patient so they can be prone, and this moves the rectum away from where we need to escalate dose, because we are trying to push this dose to about 66 gray. The rectum can only tolerate about 50 to 60 gray, and the tolerance, maximum tolerance for the bladder is about 65 gray. So we are sitting right on the edge of where we are going to get toxicity. But what are the issues that we run to when we are giving radiotherapy? As I said, organ motion. So that bladder is not sitting in the same position every day during treatment. Secondly is delineation. So we sit down to determine what are the treatment volumes that we are going to, for this patient. And if you're imaging radiotherapy was not adequate. You'll miss nodes that are sitting on the pelvic side wall. You will miss a tumor because you are told that they did a near complete TURBT and you do not cover part of the dome of the bladder. Then setup. Remember, this patient is going to be on treatment for anywhere up to 33 fractions, and every day we want to reproduce the position that we started in. Then during treatment, we take 2D or 3D images to confirm where the dose is going, and that's where radiotherapy has moved into, and what I highlighted about reproducibility of the bladder volume. But then remember that once these patients are treated, there are side effects that they will experience. During the treatment and up to 6 weeks after, they will have issues with dysuria, urgency, frequency, and diarrhea because of irritation of the rectum. Then the late effects, which is where most of the patients come in, the first one actually is usually hemorrhagic cystitis, which I'm sure as urologists you see a lot. We get issues with bladder contracture, so you find someone is going to the bathroom every 20 or 30 minutes, rectal strictures and bleeding, and this can be an issue, especially if you do not protect the rectum during radiotherapy. And because the small bowel keeps looping in and out of the pelvis, then that can cause issues with obstruction later. And you need to counsel the patients on these side effects because they are prevalent, and sometimes we don't pick them when we are seeing the patient. So what is the evidence? In this paper that was published, which is a BC 2001 by the investigators from the UK, the interesting thing is that majority of our patients did not have a residual tumor. So remember about the complete TURBT. Most of our patients don't fit into this criteria. Secondly, most of the patients who are managed, who are basically from T2 to T3, did not have neoadjuvant chemotherapy. So they had definitive chemoradiotherapy as their treatment of choice. But the radiotherapy that was given, which I said for us the standard is about 64 to 66 gray, they hypofractionated, meaning they gave more than 2 gray per day. So they gave treatment at a dose of 55 gray in 20 fractions. And that's a difference of about 2 weeks in terms of treatment. But what was the outcome? On this forest plot, you can clearly see that what was favored was chemoradiotherapy in this patient because they added platinum, with even the patients who got about 55 in 20 fractions being found to be non-inferior to the standard 64 gray in 33. And this could be revolutionary for our setting, where for most of the centers, we're still doing 66 gray in 33 patients for patients who need chemoradiotherapy. But hot off the press from the Lancet this month is a review of both the data from the BC 2001 and the Beacon trial. The Beacon trial was now using radiotherapy with carbogen and nicotinamide, and the thinking in that trial was that you get hypoxia because of the poor, either you have issues with hypoxia in the tumors that are sitting within the bladder, so could you use a radiosensitizer to make the tumors more sensitive to the radiotherapy? And that was found that carbogen together with nicotinamide added some value. There was, I think, a trend towards overall survival benefit and disease-free survival. But because of the technicalities of giving carbogen and nicotinamide during radiotherapy, that did not become common practice. But then Prof. Chaudhry in Manchester, together with her team, then looked at these 2 trials. So they were not head-to-head trial, they were looking at the data, and the BC 2001 had about 450 patients. The Beacon trial had about 330 patients, and you can look at this trial when you have time. But the interesting thing is that their patients were older in both trials, so about 70 years. The patients, majority of them, or more than 60% of them, had a complete TURBT. And interestingly, only about 30% of these patients had neoadjuvant chemotherapy. And remember, in the Beacon and the BC 2001, they looked at comparing 64 gray in 32 fractions and 55 gray in 20 fractions. So what were the outcomes? The graphs may not project so well, but I can share this paper after. There was a trend towards improvement for especially the hypofractionated treatment, and they thought this was to do with the duration of giving radiotherapy. Number 2, they tried to use, to look at how these patients, you could adapt the radiotherapy that you're giving to the bladder. And in the forest plot, it favors more of the 55 gray in 20 fractions for both of the trials. With that trend, I mean, if you look at the overall survival with the combined on the forest plot, it favors the 55 gray in 20 fractions. So maybe this is something we need to think about where we are, because I think in terms of radiotherapy technology, we can safely deliver this treatment. So what is our current situation? Most patients, I think, are still getting neoadjuvant chemotherapy with gemcitabine, cisplatin, or with MVAC. And we have seen, again, most of these patients can get neutropenic sepsis, they'll get neuropathy, they can get issues with their kidney, especially for the patients who have hydronephrosis with renal compromise. As I said, currently we're giving 64 to 66 gray in between 33 to 32 fractions with weekly cisplatin. And the issue that once you do the chemoradiotherapy, this patient needs to have a repeat cystoscopy. And that is what will give you an assessment of the bladder itself post-radiotherapy. And then we usually save these patients if they get a recurrence on those serial cystoscopies for salvage cystectomy. I'm not going to go into the details of surgery. So what do I think would be the forward plan? Number one is sitting in an MDT. And an MDT doesn't have to be a physical meeting. Now in the era of Zoom, you could have a challenging patient that we could discuss so that we also standardize our treatment plan so that we don't have somebody getting gemcitabine and then 5 years from now when we decide to review our data, there's nobody who was on a standard treatment protocol. Remember, again, these patients will come to the bigger centers like KNH, so we might have the majority of the patients. Hypofractionation, I think, needs to step up and come into the front in terms of the clinic, because number one, if you're reducing the treatment from 33 fractions to 20 fractions, that's 13 treatments less, which means less pressure on the machines. There's reduction in financial toxicity, and of course, what you said, because of the resources that are available. And I think this would help us to improve our bladder conservation rates. I thought, even though I was told to talk about T3, T4 tumors, I could not leave without highlighting about palliative radiotherapy, and this is for patients who have metastatic disease. Interestingly, again, Prof. Chaudhry, I think I saw a paper from the Palliative Society Journal, and it compared hypofractionation regimens of between 35 gray in 10 versus 21 gray in 3 fractions. And interestingly, there was no difference in toxicity. There was no difference in symptom relief. There was no difference in overall survival, which I think for us, we can consider for the patients who have metastatic disease and want to give palliative radiotherapy. Again, 10 days of radiation versus 3 days of radiation. And I think here you can see where we might have a problem because radiotherapy is costed per fraction. So you might see where we might have resistance in acceptance of the 21 gray in 3 fractions. So as I conclude, I think for now, we have robust evidence in terms of rolling out hypofractionation for radical radiotherapy. I think there is value of the shorter palliative treatments because the patient doesn't have to be in the hospital for so long. And I think the importance of the MDT cannot, and I say cannot, be overemphasized. Thank you.
Thank you. We allowed Dr. Joki some extra 5 minutes because she's an external presenter.
Please keep your questions until the end of this session. Our next speaker is Dr. Mugalo. Dr. Mugalo is a consultant urologist at Moi Teaching and Referral Hospital, which is our second level 6 facility in this country. He'll be talking to us about characteristics of patients with squamous cell carcinoma of the penis at the Moi Teaching and Referral Hospital.
Good morning. Yeah, I want to share some experience on characteristics of patients with the presenting with the squamous cell carcinoma of the penis at MTRH Eldoret. We know that squamous cell carcinoma is a relatively rare condition, and it's mainly found in elderly men. The peak incidence being in the 70s, with 60% of the cases being among men over 65 years of age. It has a poor outcome, a poor 5-year survival rate of 50%, even in good centers. Uncircumcision is the most important risk factor, and neonatal circumcision virtually eliminates the disease. It is rare among circumcised men who were circumcised in infancy. And this may suggest an irritating effect of smegma found under the foreskin. And we know smegma elicits a chronic inflammatory process with the recurrent infection causing preputial adhesions and phimosis. Uncircumcised men have a lifetime risk of penile cancer of 1 in 600 in the US and 1 in 900 in Denmark. Worldwide, circumcised males have a lifetime risk estimated at 1 in 50,000 up to 1 in 12 million, depending on where. No invasive squamous cell carcinoma of the penis has been detected in people who were circumcised in the neonatal period. And other risk factors are low socioeconomic status, cigarette smoking, HPV infection, and low penile hygiene and phimosis. HIV positive patients have also been observed to have a higher risk of developing penile cancer and other malignancies. We did a retrospective study running 10 years. This is a bit of an old data from 2006 to 2016. And we looked at the demographic characteristics, risk factors, presenting lesions, and the treatment options that were available then. We included all patients who had a confirmed histological diagnosis, and anyone we couldn't confirm the histology, we excluded, and we got the relevant approval for the study. So this is our data. The font is a little bit small, but in 10 years, we had only 41 patients. And they had a mean age of 51.2 years. 92% were married men, and 81.6% were uncircumcised males. 70% gave history of using tobacco, and 86.1% were HIV positive. The commonest lesion was found on the glans penis of 63.9% of the males, and 71% at the time of diagnosis had a fungating ulcer, which means an advanced disease. Most of them were low-income earners based on the occupation they were involved in. And the commonest treatment option was, of course, penectomy in 70% of the patients. So we know squamous cell carcinoma is still rare globally. And in this study, we had only 41 cases in 10 years, which means around 4 cases per year. And we know MTRH is a hospital that serves a catchment area of over 24 million people. The last study done at KNH by Professor Magoa, in a span of 30 years, they had 55 cases, which means about 2 cases per year. It affects mainly older men, as we said, over 70 years of age. But at MTRH, we found it was 51.2 years mean age, which implied that our patients were 10 years younger compared to information from developed countries. A nearer home, a study in Bugando showed almost the same. Bugando is in Tanzania, where the mean age, the peak age was 41 to 50 years. The 63% of our patients were circumcised, and the same study in Bugando, theirs were 89%, No, our 63% were uncircumcised. In Bugando, 89% were uncircumcised. And we know that the presence of prepuce, which conceals smegma, will elicit an inflammatory process with recurrent infections, which causes adhesions and phimosis. However, improved hygiene reduces incidence of squamous cell carcinoma. In Denmark, despite them having a very low circumcision prevalence of 2%, with the fewer cases of squamous cell carcinoma, but they found that the cancer decreases commensurate to increase in the number of indoor bathrooms or hygiene facilities. 86.1% of our patients were HIV positive, and we know HIV infection it's a high risk in developing malignancies, even in other sides of the body. And the low immunity predisposes development of cancer by failing to clear stages of cancer development. So there is increasing reports of cases of penile squamous cell carcinoma in patients who are HIV positive. As I indicated in our data, most of our patients were low-income earners. Majority were peasant farmers. A study in Brazil revealed that 70% of patients with penile cancer were common agricultural workers. So ability to maintain high level of hygiene makes all the difference, as the study in Denmark showed. So people of low socioeconomic status may not be living in an environment where they have the benefits of high levels of hygiene as people who live in high socioeconomic status. In our study, 76% of our patients underwent some form of penectomy. This is just a salvage procedure in invasive disease. And it shows that most of our patients, by the time they are presenting with lead disease. And though 92% of our patients were married, but we know that the data that we have, most of them, these are not monogamous marriage, and so they also have a high risk of developing HPV, which we also know is a risk factor. So in conclusion, penile squamous cell carcinoma, though it's still uncommon, but in our setup at MTRH, our patients are 10 years younger, and circumcision, HIV infection, tobacco, and low socioeconomic status are risk factors, and the glans penis remains the commonest site, and patients present late, requiring salvage intervention. Thank you.
Thank you very much, Dr. Mugalo, for keeping time. So we'll continue. Please keep your questions till the end of this session.
Yes, our next presenter is Dr. Francis Owira, who is a consultant urologist at the University of Nairobi and Kenyatta, who's going to talk to us about testicular tumors in our setup. Are they rare or are they underdiagnosed? Karibu, mwalimu.
Testicular tumors. Yeah. Dr. Wheeler or Wheeler. Testicular tumors. You touch which button? This one. So. Yeah, thanks. We are going to discuss I think the most important part of the body. testicular tumors in our setup, are they rare or underdiagnosed? And we are going to see that. As much as they seem to be rare, which from what we have been seeing is the commonest, testicular tumors are the commonest actually male solid tumor under the age of 50. So in young males, there's a commonest tumor. It accounts for about 1% of all cancers in the male population, but 5% of the urological malignancies, according to the UA. The incidence of the testicular tumors varies by ethnicity, but not much, because you'll find that as much as it's rare in Kenya, globally it is also rare. It's not a common disease. But it's been seen to be rising in the developed world in the past decade, according to national cancer registries. And this mainly in the developed world. The highest incidence is found to be in Norway, where it is about 11.8 per 100,000, and lowest in India, where it is 0.5 per 100,000, and Thailand. So it seems to be less in the east than more in the west. Seems to be following prostate disease. Exact incidence of testicular tumors in Sub-Sahara is unknown, but I think it's not that it's unknown, but it's rare, 0.3 to 0.6 per 100,000, but also mainly because very few researches have been done in Sub-Saharan Africa. Nini imefanyika? My friend. It has come backward. I don't know whether that's where we are. Just check.
Okay, already done that?
No, not yet. Not yet.
Yeah, good.
Not yet. Not yet. Not yet. Not yet. Not yet.
Let's start from
Just from the beginning. Yeah, I think I was there, but it's not sure. Then you moved again. And then I was there. Can I use this? Use this one. So, as I was saying, the exact incidence of the tumor is Sub-Saharan is not known, but possibly because of the researches are not done in the Sub-Saharan. People do researches where they are more concerned and where there's more interest. Now, if you check the global cancer registry for Kenya, the testicular cancers are number 30, ranked 34. If you in the register. So it means it's one of the most rare tumors after breast, cervix, prostate, esophagus being the leaders. In one of the studies, over 9-year study, 1968-1976, it was found that in a period, 40 testicular and paratesticular tumors were seen at Kenyatta National Hospital in a 9-year study. Based on the Kenya's census of 1969, the crude incidence rate was by then 0.808 per 100,000 Kenyan males. That shows how low it is. And that time, it represented 0.28 of all the cancers submitted to the registry at that time. Now, proportional distribution of the testicular aneurysm was not significantly different from findings in the states. And in the testicular tumors, the germ cell origin represents the majority, 96.5. In a study done by Pott, Eli, and Magoa, 39 histologically confirmed testicular tumors were seen between 1983 and 1997 at KNH, where the mean age was 34.8 years, with a peak incidence of 30 to 44 years. That it affects mainly the young population. More than 89% of these patients had germ cell tumors, which means the non-germ cell tumors are rare. Commonly, the seminoma, the teratoma are the commonest. Seminoma leading by 67%. 10-year experience with the testicular cancer at a tertiary care hospital in a resource-limited Tanzania, study done in Tanzania by Samson Simbila and the group, which was also a retrospective study, showed that found that testicular cancers at Buganda Hospital between 04 and 14. A total of 56 testicular cancer patients were seen, which represented 0.9% of all malignancies then. The median age of their patient was 28, with a peak incidence 21 to 30. Ours was a bit on the higher side, 30 to 44. Also, histologically, they found 80.4% of those patients had germ cell tumors, with seminoma accounting for 62%. A study by Kimutai, a cross-sectional study, descriptive study, found 138 patients, looked at 138 patients over 6 months. Patients were examined between 6 weeks. This was an ultrasonographer department, the ultrasonographic radiologist department. They were looking at testicular masses for people, from childhood to 90 years. So the mean age was 30. They found 93.5% were found with scrotal disease with high prevalence between 20 to 40, where scrotal masses were mostly prevalent at 63%. And 69% of those patients, so which means almost 70%, were extra-testicular masses. 31% were diagnosed as inflammatory, and 18% were undescended testes. In USA, they looked at pediatric solid tumors, and 1% was found to be of testicular origin, pediatric solid tumors. That is years between 1998 and 2012, pre-puberty. And they looked at a very big number. 479 patients were identified with a median age of 3 years. In China, over a period of 10 years, a total of 67 children were also looked at for testicular tumors. The patient's median age was 18 months. In a high-volume hospital in Spain, only 21 testicular tumors were also diagnosed from 1990 to June 1998. And this shows you how rare these tumors are, because those are developed countries where it's very difficult to miss a patient going without having testicular tumor, not going to the hospital. In conclusion, is that paucity of local data is a problem. You see, the last study was done by Mago and the some years back, more than 10 years back. I think we should put some effort to look at the testicular tumors. And generally, conclusion is that testicular tumors are rare tumors. They are not common tumors like other tumors. But still, notwithstanding, I think some effort should be done, should be put to look at these tumors in general. Asanteni sana.
Thank you, Dr. Wheeler, our teacher. Our next presenter is Dr. S. Kanyi, Dr. Maina Kanyi. We all know him. He's our senior urologist and our teacher. Dr. Kanyi will be talking to us about prostate brachytherapy, the science, indications, and the local data about the same. Welcome, Dr. Kanyi.
Thank you very much. You can see the title, and you can see it has a label, because I was told by the hospital that I have to put them on this screen, because this is what they have given us. So we thank you very much. We started brachytherapy at Nairobi Hospital in 1971, and we want to thank Dr. Milo, who was the CEO, because when they did the cancer center in 2070, they even went to South Africa to go and look at what was being done, and they came and did it. And they were only looking at the female to look at cervical cancer. So when we confronted him, we asked him now, so the men are not going to be treated. So he told me, well, he blew his temper and said, you mean you also need it? So it said, I'm sorry, we are going to have it. So that is how it was started. So that is why this label is there. So you see, prostate cancer is asymptomatic in the early stage, and it has no symptoms due to the local distance spent, because the prostate is like a tortoise. It has a very nice cover, which is not easy to penetrate. And we saw, when we read the pathology, we were told the prostate cancer was only for the older people, maybe people who are about 40, 70 years. But you can see now it's a bit different. So brachytherapy is what you are looking at is the equipment that we use. But you see, brachytherapy is putting some radioactive material into the prostate, and it is going to burn the cancer cells, and of course you ensure that it remains within the capsule, and it is ultrasound guided, and of course we have been talking this morning about biopsies, and we should have done biopsies. What we have is that we use a transrectal ultrasound machine, which shows us what we are doing, just like you did the biopsy. And then we have, you can see the people sitting down. These are the people who are the physicists who is going to do the dosimetry, because we have to have the prostate and ensure that it is what we can use. You know, if you look at prostate cancer, we use blood to look at it, and the biopsy must be ultrasound guided, and you have to take a minimum of 12 to about 24. And some people may use MRI, sometimes ultrasound fusion biopsies, but we don't have that. We still use the ultrasound guided biopsies. A digital rectal examination that Dr. Kimani said in the morning is also done, but don't go to the seminal vesicles. If you look at the risk factors, we discussed some of them in the morning, but you can see it was, even in America, they were saying it was ethnic, more of the blacks, but it has been known it's because of the low economic status of the blacks that now they are being told they may have it. Again, about the genetics, we have discussed this morning, and you can see that it is there. We have seen, practice, for example, young boys, the age of 30 years, coming with prostate cancer, which is already spread around, into the bones. So it is something that you have to look at about the family. The staging of prostate cancer, we know the one T2, T1, T2, and 3, and the log. We don't have to go more about that. And if you have nodes and metastases, of course you can see brachytherapy is not going to be used. And we also look at the Gleason score, which you know that if it is 1 is to 2 is to 3 is normal, and anything above that we think that this is more of CA prostate. And the score will be the least at 2, because if you started at 1, and the maximum is 10, and we know that the risk that anything about 6 or 7 there then shows that there is aggressive tumor. And the PSA, this is what we should have, and maybe even our friends who are all here, the men, we should have the PSAs done every year. And you can see, if we have seen prostate cancer with PSAs between 10 to 20 nanograms per ml, that tells us tells that the Gleason score is about below 7. We are able to do this because to do brachytherapy. But you can see, if the PSA is more than 20 nanograms, we can actually say maybe most likely we even have metastasis through the capsule. We may even have lymphadenopathy. And the more it goes, like we saw this morning, 400, we have even seen one at 16,000. And you saw that time when it was 16,000, there was bones everywhere, it was tumor. So locally advanced, locally advanced tumor usually will be above more than 20 nanograms. So staging is what then we should look at first, and ensure that there are no bone mets. And PET scan can also be done before you do the brachytherapy. But for us, what we do, we only take the patients whose PSA is below than 20. And we can see that the prostate cancer, the stage also depend on the life of the patient. Some of them, if you have, for example, 20 nanograms and you are 70, surely we should not be saying that your risk is too high, because you are still in the low area. Now, the early prostate cancer, you see that one can do what we call radical prostatectomy, but we are changing it to anatomical prostatectomy, because when you say radical, you are pulling out everything. So it is being mentioned as anatomical prostatectomy. And you can see that when you have done that and you have positive margins up to 30%, you will start getting recurrent of the disease about 5 years. And this can occur in about 30 to 100% of the patient. Of course, you have bleeding, you may have incontinence, and urethral stricture. These are some of the things that we should look at in the people who, if they can qualify for brachytherapy, it would be good we don't put them onto surgery. They should go onto brachytherapy. And there are other ways of treating prostate cancer other than brachytherapy. There is cryotherapy. Cryo means using liquid nitrogen, where you put it with probes into the prostate, and you cool that to about minus 40 degrees Celsius, and you see that kills all the prostate cells, and you only leave about the capsule and whatever cells were in the periphery. And for brachytherapy, so we also do, we have two types of low radiotherapy, low dose or a high dose. The one we use here in Nairobi Hospital is the low dose, and we use iodine. Iodine seeds we normally get them from the US, but now we are going to be getting them out from the East, and they have been very expensive. But when you put the iodine seeds, they burn the prostate cancer cells or the prostate tissue cells, and if they are put properly there, then we have very good reports. Of course, you can see the low dose iodine. We are using at iodine 125, or if you can use palladium 1.0103. Palladium has to be put in with big needles and to stay there for some time. But iodine, we just do it easily. Others are high dose iridium. So for us, we are looking at the so-called interstitial radiotherapy, and also brachytherapy. This brachytherapy is using the iodine. The choice of the patient or selection of the patient, not everybody every patient would qualify, because we are looking at the PSA. We have said maybe below 20, and below 20, but 20 we have changed from saying that PSA less than 20. You can see we do not have any cancer at over less than 20, less than 10 nanograms. And the prostate size must not be larger beyond 30 grams. And you have to take about 50% of biopsy course which has not much of cancer. And as you have done that, then you will be able then to look at which patients are you going to take. Not everybody with prostate cancer can qualify, because if the prostate is too big, you are not able to put the seeds in all the area, because the dose of radiation would be too much, and it will affect the patient more. And the PSA must not be more than 20, because above 20 we see we have metastasis either into the capsule, and of course we have, for all the patients that we do, we must have had brachytherapy, we must have MRI. So this is still part of the prostate, and you find that if you have had done TURP, prostatectomy, see, the seeds will not have a place where to put them. So we will not take, unless this patient has been a few years and maybe after TURP and he has enough tissue that we can put the seeds. And the other thing that we do have that sometimes is even if the patient has a prostate with a median lobe, which is bigger there, we may have to resect the median lobe so that we can remove the tumor properly. So the implantation of the seeds is at a general anesthesia, and we use a probe, a transrectal ultrasound probe, which is, and you see this probe comes with a machine, where we are able to put that probe with the patient in lithotomy. We put the probe in, and we have an ultrasound machine, and that machine is then connected to the probe so that we can be able to see how big is the prostate, and we look at the margins, and then you go on, and you use computer software. BK Medical from the Netherlands have a workup on that computer where you can be able to look at where are you going to put the seeds. That picture there shows, is it possible? Can you see a picture with small? No. Okay. We'll see it as we go on. Yeah, this is what those small things you can see there are iodine seeds, which we have put now into a patient there. All those, and we put them looking at. You have to look at the capsule. You don't go beyond out of the capsule, and you don't look. This is an AP X-ray with and you can see the pelvis there. You can see the upper lemurs and the pubic symphysis there like that. You can see the prostate will be behind there. So this is just the X-ray showing where it is done. So we are trying to avoid complications, because if you put these seeds and they go to the urethra, you see you are going to burn the urethra, and therefore you may have strictures or you may have leak of urine as you have done that. So and you see sometimes you can see the seed implant. You say that you don't want to put urethritis, because you may even increase frequency of urination. Sometimes you may also urine retention. The worst is for the seeds to migrate. Some of them have migrated to the lung, but they have been reported, but we have not had such a thing. But as you put the seeds, they must get the prostate properly. But you see, if you hit a vein, then that seed is going to go all the way to the heart or maybe to the lung. So you must be careful. So, and you aim at, to cover 90% of the gland, and but you should have gotten about 140 gray of radiotherapy, so that you are going to cover the prostate and the prostate fully. And this will give you a very good outcome. But if you don't cover 90%, then you have not have covered everything. So we also do have complications like urethritis, like I mentioned, urethral retention, migration of this side.
We will ask you to try and summarize, Dr. Kanyi.
Yeah, some of the things that we have done, we have done about from 2017 up to now, we have about 80 patients. And the good thing about that, the PSA goes down and we follow them out. I know my time is going, but sometimes if you find that we have not covered the area properly, if the prostate is a bit bigger, we do external beam radiotherapy, we add a retro. But you can see one thing is that we are not operating on the patient. The patient remains normal, and that is what we call looking at both of them. Our problems is if you just, for surgery, I'm not saying that it is bad, but we have a lot of problems. Patients come to you and they say, now, why are you? You never told me that I'll never have erection, I'll not have ejaculation. And the wives even come and ask you, now, was this what was going to happen in our family? You never told us we should not have agreed to be treated. Of course, you can see some other things that, for example, this one we do not see it, but you can all make your diagnosis. It is bone mets, isn't it, of tumor. And that is not for brachytherapy. But this was when we started in January. You can see somebody there. On the left, you can see Professor Mungai somewhere there. You can see on the man on the jacket on the left. On the right, there is Mr. The Abuao, the oncologist. And that is what we did those in January 2017. And that is what the patients say. Well, can you reverse? Some have gone to India and come with the radical prostatectomy, which is being advocated, and we are not able to. Have we finished? Sorry. So for us, you see that if you are going to give brachytherapy, you leave this patient's body intact and you have treated the cancer. But this is only for prostate cancer in early stage where the PSA is about 20. And the side effects you can see are minimal as long as you make sure that the seeds are within the prostate. So you have not gone out of it. And this is one of the best things to do. But you see, right, this is the anatomical prostatectomy is also needed because sometimes it is the only way to do it. Thank you very much.
Yes, we had given leeway to Mwalimu a bit because he's not had a presentation with us for quite some time. But I'll be very strict going forward. Our next speaker is Professor Alice Musibi. Professor Musibi does not need much introduction. She is in medical oncology, practicing at both Kenyatta National Hospital and the Nairobi Hospital. She's going to talk to us on targeted therapies for metastatic renal cell carcinoma. Karibu, Professor. Professor is a guest speaker, so she will get 15 minutes.
Good morning.
Morning.
think they have to go to Nairobi for my presentation, but we can take a few minutes. Matu, how many ladies are in this conference? Huh? I'm just trying to add why we are so many more than the men. Don't judge from the dressing. But I've always wondered why women are more in this forum more than the men. Huh?
Yeah, as we set up, perhaps we can have one or two quick questions for the presenters for the morning. Dr. Misango?
Is it possible to do what is an equivalent of pre-brachytherapy chemotherapy so that you can be able to shrink the cancer first, and then hopefully you can be able to do the brachytherapy, or it's completely reserved for very early prostate cancer?
He's asking whether there is a role for neoadjuvant chemotherapy, where the adjuvant treatment here is brachytherapy, Dr. Kanyi.
See, what are we looking at? We are looking at the anatomy of the prostate, from the capsule all around it. And you see, medical treatment is also going to cover it, but does it kill all the cancer cells in the prostate? It doesn't.
Yeah.
So we are looking at this, the prostate cells to put in to burn, although it may not burn everything of the prostate. But you see, as you put it inside, you put all those seeds inside, you kill most of the cells. And we said there is a computerized way of looking at the prostate and look at the seeds where they are going to be distributed. They are not going to be in one area, but throughout, looking at it, and that is, you leave the capsule, okay, you save the urethra, and that burning of the cells, we think is what helps us. You can still continue with the medications, but you see, I said, we also do have external beam in case we find that we are not satisfied with what we have done.
Yeah, thank you. We will discuss that further. Professor Musibi.
Thank you, organizers, for the opportunity. I believe we now know this topic by heart because we've had it for the last few years. But what I will add on what we did last year is just the new findings that may have come up. Are we able to move along with the times, with the management of our cancers, or are we still mark-timing where we are? I don't need to remind ourselves of what RCC is. Majority in kidney cancers, majority are RCC, and those are the histologies. Diagnostic workup, again, is a reminder to ourselves. If it is suspected, what is indicated, what should we do? This is dependent eventually on where you are, what is affordable, and what is best for that particular patient. But the guidelines are the scanning, a bone scan if indicated, and again, debate that never seems to end, who needs a biopsy and who does not. Again, it is dependent on who you are, where you are, and the circumstances. But the one line is, if by the end of the day you are going to do surgery for that particular patient, then you don't actually need a biopsy. But what would be the indication of the biopsy is to determine in those small masses, what would it be? There could be other comorbidities. If they have HIV, you want to rule out possibility of other issues, TB, which is treatable lymphomas, because you don't want to remove a kidney when it is a lymphoma. And also, eventually, considering we are now moving into molecular medicine, you also, in some cases, you want to do molecular studies. Now, this again is a reminder to ourselves of eventually how do you risk stratify your patient to enable you offer them the best type of management. Favorable risk is as far as indicated, and intermediate poor risk. But by the end of the day, the treatment options is also as shown in step 3. They are those ones that you'd want to observe, but it is not observed in their houses. You need to keep seeing them, the active surveillance. They are those ones you want to give active treatments. Would you choose injectables, or do you go for tablets? There is also a role for radiotherapy, and eventually we have those that may require combinations of all these treatments. Now, when it comes to renal cancer, to the kidney cancers, RCC, the cartoon there just shows us what pathways, the pathogenesis we are looking at. In the beginning, we thought of chemotherapy as the answer for us, but over time, it has actually been relegated to the back room because of all these pathways that have actually been found. And as you can see, there are specific areas that also come with specific drugs. What does this tell us? That by the end of the day, management of metastatic renal cell carcinoma may not be on a single agent. It might be combination of different agents considering the different pathways and involvement of different enzymes, different molecular pathways. Can we actually manage that in this country? Yes and no, and we'll see that. But like any other cancer, the message is it is not a one-person tumor. And I know we always discuss these tumors in our tumor board in Nairobi Hospital, and there is always the discussion, who goes first? The surgeon, the radiation oncologist, or chemotherapy or immunotherapy. And it actually gives the patient a better outcome by the end of the day when this decision is actually made upfront and not when one thing or the other has been done. The return discussion for any patient, whichever cancer it is always best when the pathway is actually drawn from the beginning. And it is a request to all of us, even if it is not the virtual or the physical meeting to discuss a patient, you can liaise with any of your colleagues to actually have a way forward for the patients. And like now with tumor boards that are virtual, there is no reason why you can't give benefit of, give your patient benefit for that discussion. Now, since last year, when we had the same talk, where have you been? From 1980, the drugs keep changing. For the better, yes, and what we knew keep getting lesser used and almost falling off from the management. Last year, we were talking about how many of our patients are on sorafenib. If we look at this cartoon, you may not even see where it is, okay? Because all the drugs that are new and have been shown to actually have an impact on metastatic RCC are the targeted treatments. Do we have these drugs? We have some of them. Are they affordable? Maybe to a minority of our patients, but by God's grace, maybe 2040, things might have changed when one of you becomes the president and they can manage the NHIF fund. And we should look forward to that, because by the end of the day, oncology seems to be given a raw deal as far as financing is concerned. Now, last year we had this study, the Checkmate 214, which was a comparison of the sunitinib and nivolumab versus nivolumab ipilimumab. Now, to some extent, maybe as we go by, it didn't come out what people expected, but all it shows, it goes back to the IMDC risk profiling. Which people would you rather put on this treatment and not the other one? And the hazard ratios there say it all. In our circumstances where the of one combination, nivolumab ipilimumab, is not accessible totally, you have no reason not to give it, the patient sunitinib, because the outcome is not inferior. Overall, but it is specific for the poor risk. And those are the patients that you want to put on medication. The favorable risk also can be observed depending on where the patient is as far as finances is concerned. Now, the good thing with this is, I'm not sure how many are aware that sunitinib is free, can be freely available in this country. How many are aware? One. So, sunitinib is available in a program that is run by Professor Abinya in Nairobi Hospital. Initially, it started as a program for chronic myeloid leukemia, but I think it is now open to anybody who can benefit from sunitinib. And considering the fact that sorafenib that we used to talk about so often is almost getting off the radar for treatment of RCC, maybe this is our next option. So if you have any patients, it is good if you refer them for assessment and maybe they can benefit. Buying for the patients, I think it comes to $500,000 a month, which may not be accessible for majority of our patients. Now, the other study that is good to look at in this RCC is a keynote, which shows advantage of sunitinib on, this is sunitinib in combination with pembrolizumab and axitinib. They are all huge names, and you really have to know how to present them. But again, we are talking molecular management. Overall survival, like we said before, over a few months in oncology can mean a lot. I had a patient yesterday, not renal cell, but breast metastatic to the brain, has had surgery, has had radiotherapy. And the father said, if I can see that lady one more day, it would make a difference. Now, in RCC, people can actually live for quite some time, depending on the risk classification from the beginning. The overall survival was definite, obviously superior to the combination than the sunitinib, but right now for us, sunitinib is what is available, and I believe we can give a few months. 36 median overall survival of 24 months with metastatic renal cell carcinoma is something to actually celebrate, so long as you keep observing them and they are not coming down with side effects. Because the trouble with all these molecular and immunotherapies is the side effects that actually come with them, the mucositis, the hard foot syndromes, the liver derangements. With good follow-up, patients are doing much better. Of course, again, what we need to look at is the difference between the intermediate poor risk and the favorable. There's no study, the ones I've looked at, that the favorable risk seem to do better on any medication than the poor risk. What does that say? You can actually give an opportunity for the favorable risk to stay off medication for some time before you actually start them on medication. You don't want to make their life a bit more miserable than the tumor they have. And these are the response rates up to now. The newest combination is what we have seen in the keynote study, axitinib and pembrolizumab. And this is where, again, where we talked about molecular mapping and for the pembrolizumab. The newest is checkmate, comparing again nivolumab combinations, cabozantinib, and we are remembering the initial cartoon of the different steps in the cell cycle of where all these things you can check for progression of the renal cell. Again, significance with the overall survival improvement. It's a few months, but again, it still makes a difference in any patient. Overall survival for these particular combinations has not yet been reached, and most likely, when I'm invited next year, this is the study we shall look at of what has happened. Now, a cartoon summary of what are the recommendations once you do the stratifications is what combinations would you want to start with? And this is what is now in the guidelines. Within all these combinations, the only available drug with us is a cabozantinib, and we have a generic. It goes for more than 150,000 per month. These are drugs that somebody has to be on for life or until progression. So the finances is what is the downside for us. Sunitinib, I've said. Pazopanib is also available, but it also comes to more than 500,000 every month. Good risk, intermediate risk, poor risk. And the different combinations are as shown there. We are back to our NCCN guidelines. This is the latest version, and it also guides eventually on what you should choose. Well, we still, in this country, still stuck on the sunitinib because that's what's accessible for most of us. Otherwise, it is best supportive care. What are the new side effects that we really have to deal with? Mainly is the mucositis, and sometimes it gets too bad that the patients actually may not tolerate the drug. What sometimes we forget, since they are all oral medications, is the follow-up as far as cardiotoxicity is concerned, so that some will get into CCF. And remember, some of them also have comorbidities, hypertension, and we may not actually relate the two. So follow-up every other month or every other week, depending on what patient you started with, is quite important. Pruritus, myalgia, those are things that we need to actually keep asking our patients every time we see them. So a summarizing cartoon, which actually has almost everything on the risk, the statistics. This is just in passing and reminding us where we are. There are some drugs that are already been approved by FDA, and sometimes you say if FDA is using, who are we not to take them up? Our trouble is just the cost. Thank you.
Thank you, Professor, for that stimulating talk. We will go to a virtual presentation. We will let Dr. Nguku, S. Nguku, from Radiology Department, Aga Khan Hospital, to present online on the novel imaging and diagnostics in prostate cancer. Dr. Nguku, I don't know whether you can hear us. He's listed as S. Gitau. Samuel Gitau?
Yes, I can hear you. I don't know whether you can hear me.
Yeah, we do. We can hear you. We allow you to share.
Please, if you could just allow me to share my screen, yes.
Yes. A minute. Share now.
It's still not allowing me to share.
Just a minute. Try sharing. Yes, we are up.
Yes. Thank you very much. I would like to appreciate the organization and the leadership of CAOS for inviting me to give this talk on the novel imaging and diagnostics in prostate cancer. As has been introduced, I'm a radiologist, but I also have a nuclear medicine training, and I work here at Aga Khan Hospital. So we have come a long way in terms of imaging of prostate cancer from, the good old ways of just doing a simple ultrasound. Then we were able to do some CT scan imaging, then MRI imaging. And of late, the shift has been to do molecular imaging, whereby we are looking at more of the function and the cellular level of function of tissues rather than just the anatomy or the texture of pathologies. So we do have a few forms of molecular imaging or functional imaging, also called the new generational imaging, NGIs. And functional MRI is one big one, and there's a lot of research and interest going on in this because of its non-radiating nature. So there is no radiation involved. Then we've had sodium fluoride, which is a bone-seeking tracer. So the four listed below the functional MRI are all PET scan modalities. So NAF, F-choline and carbon-11 choline have also been used, especially in Europe and partly in America. And then flucyclovine, very popular with the Americans, especially now that they had not had FDA approval of PSMA. But of course, the biggest one when it comes to molecular imaging of prostate cancer is PSMA, which stands for prostate-specific membrane antigen. And this has been really a game changer in terms of prostate cancer imaging. I think last year we were speaking about this talk, and the FDA had not approved PSMA for use until December 1st. There was approval for 2 centers in America for use of PSMA targeted PET tracers. And this, of course, will make a big difference in terms of the use of PSMA all over the world. Just a brief on what PSMA is. It's actually an antigen, a glycoprotein across the membrane of cells. And it has 2 components. So there is an apical component, which is the biggest component that is extracellular. And we also have a cellular or cytoplasmic component, which is within the cell membrane and within the cytoplasm. So what traditionally people were actually using was, this PSMA was first described in 1990s, early 90s. And initially, the first tracer that was developed was prostasynced, which was being bound to indium-111, but there was a challenge with the image quality, very poor quality of images, basically because of 1, we were using SPECT imaging, and 2, because it's binding to the smaller component of PSMA, the target to background ratio was very poor. So in the early 2000s, there was a lot of interest in development of antibody ligands that would bind to the extracellular component. That led to a development of gallium-68 PSMA-11, which has been greatly researched. And in the recent past, we do have fluorine-18 PSMA, which is what we have here at Aga Khan. So what is important to note is that PSMA is overexpressed in prostate cancer cells, 100 to up to 1,000 times compared to the normal cells. But unfortunately, this is not a specific tracer, as the name would suggest. Is actually a misnomer. PSMA is also expressed in endothelial structures. In fact, there is a lot of research ongoing on its use in evaluation of other cancers, especially in the brain, and also HCC and renal cell carcinomas because of its high expression in endothelial cells in neovascularization. And in the same sense, of course, if you have inflammation and there is increased vascularity in that area, then there is also increased PSMA expression, but not the magnitude that we see with prostate cancer. Just a brief mention of why gallium-68 and PSMA are a bit different and what is better versus the other. So what we have is F18 PSMA, and one of the biggest benefits is that it has a longer physical half-life, so it's 120 minutes compared to gallium-68, which has about 68 minutes of half-life, which means you're actually doing a race when it comes to imaging of patients. And also one other big benefit we have seen is that it has lesser blood activity excretion, which compared to gallium-68 PSMA, which makes it very optimal for imaging of the prostate bed. Just a picture of our cyclotron, which is a Gentrace. It's a small unit of a cyclotron. We're able to generate, to produce about 7 MeVs of F18 every day. And this is our PET scanner. So it's a GE machine, Discovery MI. So it has 64 slice CT. And in the front here is the rings of the CT scanner, and at the back there is the detectors for the PET. Procedure is fairly straightforward, very similar to a bone scan, really. So you don't need to fast because there is no glucose here involved compared to FDG. After you inject the tracer, the patient can either walk around or just remain in a room. We tend to keep them in a room because we have a few rooms available for about 60 to 90 minutes before we do the scan, which will take about 20 minutes. What is important to note is the radiation dose that compared to bone scan, which has about 6 to 7 millisieverts, it's about 7 to 12, depending on the dose that is injected and the nature of the CT that is acquired. If you were to do, say, a bone scan and a CT, maybe for other staging purposes, then of course the radiation dose will be higher. When it comes to clinical indications, we do have guidelines available from the European Association of Urologists, ENM, which is a European Association of Nuclear Medicine, and recently SNM. So you'll notice that this tracer has been widely used in Europe and Australia. So most guidelines have been established in those countries compared to the America. And what is of high clinical yield or value is, of course, biochemical recurrence, where we looking at patients who have been treated with clinical treatment, with curative treatment intent, with biochemical failure, where the PSA is rising below 10. If it's above 10, then of course you can do conventional imaging. You can use other conventional imaging modalities. For primary staging in patients with high-risk cancer, using the DiAMICO risk classification, which has already been described, then there is also a role of trying to look for other sites of disease. If you're looking at low-risk and intermediate-risk patients, the clinical yield is not very important, but there's a lot of research ongoing. For routine follow-up, again, not very well established, the value of PET PSMA, but we'll have a discussion around that. Of course, if you're going to use the diagnostics, you will need to have a baseline PSMA scan for you to be able to use lutetium-based diagnostics. I just checked NCCN guidelines regarding PSMA, and they are still, actually they have just highlighted that area that the discussion update is in progress. FDA just approved this last year, so PSMA guidelines, as far as NCCN guidelines are going to be updated, I'm sure, in the next coming few weeks or months. We will not go through this risk stratification because it has already been mentioned by Dr. Kanyi, but it's important to note that patients with Gleason score of 8 and above, a P2B cancer or a PSA of above 20 are high risk, and would be considered for, it would be nice to do at least a PSMA scan before considering treatment with curative intent, because of the small potential or high risk of them having metastatic disease that may not be identified with conventional imaging. So what have we done here? So we started the PSMA scans last year in June, and so far we have performed about 220 scans. By the end of last week, we do our scans once a week, about 10 cases a week, depending on the volumes that we have. And as I've already said, and based on the clinical indications, you have seen that biochemical recurrence is one of the big ones. But in our setup, primary staging has been the biggest indication for prostate cancer, for PSMA scan imaging. We do have a few cases that come for, say, follow-up on treatment, restaging, rising PSA that is above 10, so not really a true BCR. We did see a few of those cases. I'll just go through our experience locally. And as I said earlier, biochemical failure in patients who have been treated previously with curative intent, either with surgery, that is prostatectomy, or brachytherapy, or even external beam radiotherapy with curative intent, then are starting now to have a rising PSA. And we were able to identify in, I think, 50-something patients, 89% of those cases were able to identify the sites of disease recurrence of patients with PSA between 0.2 and 10. And for patients with PSA above 0.5, the rates were actually higher, close to 95%. And most of the recurrence was in the surgical bed, so at the site of prostatectomy, and in the pelvic nodes. Especially for patients who did not receive, who had just received prostatectomy without any adjuvant, other form of adjuvant treatment. About 40% would have recurrence in the abdominal nodes and skeletal sites. What was important to note, we did not see any recurrence with PSA below 10 in supra-diaphragmatic nodes or any visceral metastasis. And this data is actually similar to what is available in the literature in terms of sensitivity and the specificity of findings with PSMA PET. I'll just show us a few cases. This was a case we saw last year, I think beginning of June, who had prostatectomy and presented with rising PSA. I think the prostatectomy was about 2 to 3 years back. PSA was rising, it started at 0.02 and then went all the way to 0.5. The PET then showed these two focal areas of uptake within the, just at the root of the penis. We were just wondering whether there is something there, and we recommended possible, site of recurrence. There was really no other site. The patient went on to have ADT, and a repeat PET at the end of last year did not reveal any residual disease of that PET. Another patient here had robotic surgery, 2018, PSA is rising, 0.72. And we can see, there is a small focus in the, so that's a prostatectomy, just at the retrovesical junction. And on the left side, there's a small focus of increased PSMA uptake, which represents a local site of disease recurrence. Again, no other site. And these patients would more or less benefit from localized treatment. It's not always that sensitive. I guess raises possibility, the question of whether we are still looking at a not 100% sensitive scan. And we are not there yet, really, because these are two cases with rising PSA and negative PSMA scans. And, it brings the question of, the tip of the iceberg theory, where we think we are still seeing most of it, but there's still so much that we don't know in terms of cancer and where it is located. Sometimes it does get very ugly. Patient here, which was very interesting, PSA was rising after brachytherapy and neoadjuvant hormonal therapy. It was only 5.9, so not significant rise. just 5.9, and you'll think maybe you'll find a few sites of disease, but lo and behold, patient had extensive skeletal metastases, and there was also recurrence in the prostate bed. And I thought the PSA was maybe erroneous, has been repeated twice and is still in the same range. So you wonder whether it's a dedifferentiation of the cancer to a small cell variant. But again, it would be odd for it to be picking up PSMA. So a bit of an interesting case. In terms of primary staging, so we have seen about 83% being high risk patients and about 16% intermediate risk. That can generate a bit of debate, because ideally, if you look at you have to be being to the guidelines, it should just be high risk patients. That makes a big difference. What is important to note is that for patients whom we had a baseline either MRI, CT, or bone scan to compare with, PSMA PET resulted in significant change in findings in the N and M, which is very important in terms of staging of the cancer. And some of these nodes were so small, like 3 millimeter nodes, which begs the question of, when you're doing conventional imaging with MRI, we are looking at nodes more than 10 millimeters. So nodes 3 millimeters or less would never have called it on conventional imaging. So PET here was a big game changer for these patients. Another thing that we have noticed is that mesorectal nodes are actually quite common with prostate cancer, which was an area before not identified before PSMA PET came in. And this has resulted in, the concept of, even when you are subjecting a patient to prostatectomy, we do not, of course, do a, mesorectophageal resection. And we are seeing that uncommon sites of recurrence and of disease involvement is our mesorectal nodes. And, how do we go about managing patients in terms of their prostatectomy? So I just had again a few cases that I'll show us, which we thought there was change in staging of patients. So this is a patient who had an MRI that suggested a localized disease, stage 2B N0. PSA was 21. I think the Gleason score was 7. I don't remember, I think it was 7. And already on the PET PSMA, you can see there's disease within the prostate, and it seems to be on both sides of the gland, which already means it's a T2C at least. And there were tiny nodes. There's a node there, right, external iliac, and a small node here along the left common iliac chain. And these are so tiny on the CT, you can actually hardly, see them. You would have easily dismissed them as reactive or nothing on the CT. So again, this moves from an N0 to an N1 disease. This is a case from last week, from one of you actually, and again, a localized disease on MRI T3B N0. PSA, interestingly, again, was very low, 0.5, but Gleason score is very high. So very good indication, again, for a PET PSMA. Here we did see fairly diffuse disease in the prostate gland with left obturator node involvement, and there was also a focus in the bone. So this was not picked on these two are not picked on the MRI, so it moves from an N0 to N1 M1 disease. Other case here, bone scan, PSA was 20, bone scan, Gleason score of 8. So again, a good indication if you are to follow the guidelines, high risk patient. Bone scan was performed initially equivocal lesions, query degenerative, and you have seen a lot of those with bone scan reports. PSMA PET is, quite dogmatic in terms of giving the findings. Bone mets are clearly there. You can also identify nodal disease in addition to evaluating the prostate bed. And again, some people would argue in a PSA of more than 100, there's really no value of doing, you can just be comfortable with, a bone scan. But again, look, you might be missing visceral metastasis, which you might not see on a bone scan. And PSMA PET may, in this case, serve as a one-stop kind of imaging modality where you're able to see everything. So this patient has, primary disease, skeletal metastasis, nodal disease, liver metastasis, as well as lung metastasis. So of course, if you had done a bone scan, then you would have needed to do a CT. In this case, one exam gives you all the answers. So again, the debate when it comes to the role of PSMA PET in primary staging. This is a big research that was done in Australia by Professor Hoffman, published in the Lancet it's called the Pro-PSMA study. It was a phase 3 trial. They were comparing conventional imaging with PSMA PET. So they randomized patients into those two arms. And these were patients who had high risk prostate cancer, primary staging. And what was important is that to notice was definitely superior accuracy of PSMA PET compared to conventional imaging. There was greater treatment impact in terms of change of mode of treatment. A few uncertain results, the equivocal nature of bone scans and CT, sometimes we don't know whether this is true disease or not. PSMA reduces that uncertainty. Also important to note is that the radiation dose, if you compare doing a bone scan plus a CT or a bone scan plus some other form of conventional imaging, the radiation dose with just doing a PSMA PET is less. Of course, the debate will still go on whether all patients should be subjected to a very sensitive mode of imaging.
Why not,
to being subjected? Okay, I'll just wind up quickly. Yes, sorry. Okay, but we need to be aware that as much as we are trying to be very sensitive, we could be just chasing a wild goose because we are still not seeing everything else, as I mentioned with my slide on the iceberg. And the debates still go on regarding the value of detecting the disease early. Does it actually lead to survival, better survival characteristics? There are so many now phase 3 trials going on, so we'll still know an answer. But what is a challenge now is because we already have this very sensitive imaging modality available. Should we alter patient care based on what we are seeing on the PSMA PET? I think I will leave this for discussion. I'll just have a quick mention of theranostics, and this is where we basically bind either an alpha or beta emitter to a radiotracer that can then be used for treatment. And when you're treating prostate cancer, you do get to a point where you are dealing with a castrate-resistant disease and you don't know what to do, and that's where when you have come to your wit's end, that's where theranostics come in. So you bind the radio tracer, which is an alpha or beta emitter, to a ligand that goes to the cancer cell, and that's basically the whole concept of theranostics. So beta emitters, alpha emitters are better compared to beta emitters, but more difficult to produce because alpha emitters have a shorter range of travel and high energy that is deposited, so they are more potent compared to beta emitters. So this is how lutetium-177 basically works. There are so many clinical trials ongoing. When I just searched the other day on clinicaltrials.gov, you can see there are already 42 studies on prostate cancer with lutetium therapy. This big one, this is a phase 3 trial, and I think Vision trial, this will give us a very significant direction in terms of the role of PSMA diagnostics in prostate cancer treatment compared to other conventional ways of treatment. And just show you a few cases of how this can be effective. So baseline patient with castrate-resistant prostate cancer, and after four cycles, you can see very good response. After 6 cycles, very good response. So the big question is whether this can be sustained, and that's what the phase 3 trials will show us. I guess another case of actinium-225, which is an alpha emitter. As I said, they are more potent. Disseminated disease, very good response after 3 cycles, an additional 1 cycle, a sustained response with correlate drop in PSA levels. So in conclusion, I think we are really struggling with a modality that has very increased sensitivity, and whether or not it will it adds to a clinical benefit. I think I can put my money on it being a one-stop shop very soon, and you can already see that clinicians really love, the fact that you can just get all the answers from it. Big question is whether we should be treating everything we are seeing, and someone has actually asked, yeah, it's positive, but who cares? You can go on and do what you had planned to do, because this small size of disease may not necessarily mean the patient will do badly. And then, of course, diagnostics is a game changer. Thank you very much, and sorry for taking a bit of more extra time.
Thank you, and we would urge you to remain online for briefly, only 10 minutes, which we are going to allocate Dr. Madenge, so that then we can consolidate the questions and save a bit on time. Dr. Madenge, are you on?
Yeah, good morning. I'm on.
A minute and you'll be uploading. Kindly keep your questions. We will keep it very brief and precise. Be very brief with your questions, so that then we can try a bit and catch on some lost time. Dr. Nguku, I hope
good morning,
you have
everyone.
stopped sharing.
I hope you can see my screen.
Yeah, we are on. You have 10 minutes, Dr. Ali? Yes, proceed.
Is my screen visible?
Yes.
Okay. Thank you very much. My name is, it is, yeah. Okay, thank you very much. My name is Dr. Madenge Samuel, fifth year urology resident. So I'm going to, just a second. Yeah, so I'm going to have a presentation concerning cardiovascular morbidity in prostate cancer treatment. So as an introduction, prostate adenocarcinoma is a hormone-sensitive malignancy, and its growth is primarily dependent on androgens. So in our setup, there is widespread use of androgen deprivation therapy due to late detection of CA prostate at an advanced stage. This is as a result of inadequate screening programs. According to Kenya Demographic Health Survey in 2014, only 3.9% of men reported ever screening for CA prostate. And because of that, a study by Wasike and Magoha in 2007 revealed that 87.5% of patients in Kenya present with advanced CA prostate. So therefore, they are mainly amenable to ADT as opposed to curative therapies. So ADT can be either surgical or medical, and is a mainstay of treatment of metastatic CA prostate, and as an neoadjuvant in high risk and locally advanced CA prostate. So, however, ADT has significant side effects that affects quality of life, which include sarcopenia, osteoporosis, hot flashes, sexual dysfunction, diabetes, depression, and gynecomastia and cardiovascular morbidity and mortality, which we're going to talk about. So what is the epidemiology of cardiovascular disease with ADT? Cardiovascular disease is a major cause of non-cancer related death in men with prostate cancer. According to our surveillance, an analysis by SEER data, it revealed that cardiovascular disease accounted for approximately 25% of deaths among men with prostate cancer occurring in the mid-90s. And because of these significant deaths, it prompted organizations to form a committee, a scientific committee, to probe data concerning this, which we shall review later on in the presentation. Other studies also, a meta-analysis of 6 studies with patients receiving ADT and those who did not receive ADT showed that the risk of cardiovascular mortality was 17% higher among those receiving ADT. These are just other studies that show an increased risk. Meta-analysis observation studies found that 40% increased risk of non-fatal cardiovascular disease in men with prostate cancer who used ADT. Another study also showed a 20% higher risk of cardiovascular morbidity compared to men who did not receive ADT. Another point to note is that there was similar risk among patients who, it is not dependent on the type of ADT, whether it's surgical or medical. All of them showed to have similar risk. So the question is there conflicting data because other studies, as for example, a study by European Organization for Research and Treatment of Cancer did an RCT comparing men treated with 6 months of ADT versus 3 years of ADT for locally advanced CA prostate, which showed no significant difference in the incidence of fatal cardiac events. And also another study comparing patients with at least 6 months of ADT, that although there was increase of risk of diabetes, none of them showed an increase in myocardial infarction or sudden cardiac death among the group on ADT. So this means there's conflicting data and there's need for more prospective data to qualify this. So what is the pathophysiology of cardiovascular disease secondary to ADT? It can be one, directly or indirectly. So the indirect mechanism is what is well established, and this is by inducing atherogenic metabolic changes, mainly hyperglycemia, dyslipidemia, and obesity. Significantly, it's been shown in a 3-month prospective study of non-diabetic men that ADT significantly increased fasting plasma insulin by 26 sugars, rather, increased fasting plasma sugars by 26, sorry, that was supposed to be sugars, and decreased insulin sensitivity by 13%. And also there was continuous increase in total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides, and also obesity. Mechanism of direct injury is by direct cause of CVD disease was by injury, endothelial injury induced by inflammation with subsequent atherosclerotic plaques. So that is a summary of the metabolic effects of ADT. Basically, what was just a summary of the previous slide. Based on prospective studies on the effects of ADT on cardiac risk factors, we can see mainly obesity. There is increase in obesity, increased fat mass, serum lipids. However, to note of among the serum lipids is that also there is increase in HDL cholesterol, which is what we call, it is a good cholesterol and is cardiovascular protective. There is insulin insensitivity with increased fasting plasma insulin and decreased insulin sensitivity. Should be fasting plasma sugars. So of note also is that there is no significant increase in blood pressure and waist hip ratio, and there is no also significant increase in C-reactive protein. And so now, as we said, because of the previous study that shows a significant increase in occurrence of cardiovascular disease in patients on ADT, this had prompted formation of a committee in 2010. It was a joint committee by the American Heart Association, American Cardiac Society, American Urological Association, and Association for the Radio-Oncologist, American Society for the Radio-Oncologist. This joint committee was formed in 2010 to evaluate data, available data on the relationship between cardiovascular disease and ADT, and also to come up with recommendations of management of patients who have risk for cardiac disease. And we're just going to go through what their findings were.
2 minutes.
And the finding was in patients, identify and screen patients at risk of cardiovascular disease with history of myocardial infarction, CVA, cardiac failure, hypertension, and DM and metabolic syndrome, and have regular cardiovascular monitoring. Also, they recommended intermittent regimen of ADT to reduce risk of progression to castrate-resistant prostate cancer and also diminish ADT-related side effects. They also recommended patients with cardiac disease receive appropriate secondary preventive measures, which include exercise at least 3 times a week, nutrition low in salt and fat and rich in vegetables and fruits, to minimize and avoid alcohol, patients to stop smoking, maintain a waistline of less than 37 inches, and a BMI of less than 25, blood pressure of less than 130/80. Also to monitor and maintain optimal blood sugar level, lipid profile, and aim at glycated hemoglobin of less than 7. And for junior aspirin for patients with cardiovascular disease pre-existing. However, the same Joint Scientific Committee advisory stated that there is no clear indication for patients for whom ADT is believed to be beneficial to be referred to internists, endocrinologists, or cardiologists for evaluation before ADT. That is one of the statements from the committee, guideline statements. Also, they state also there is no reason at present to believe there is a role for specific cardiac testing or coronary intervention in patients with cardiovascular disease before initiation of ADT. Furthermore, they also state that the decision as to whether or not to initiate ADT in patients with cardiac disease in whom the benefits of therapy will be weighed against any possible risk is most appropriately made by the physician treating the patient with the prostate cancer, which is the urologist or oncologist, is left with that decision. So they also state that given the metabolic effects of ADT, it is advisable that patients in whom ADT is initiated be referred to their primary care physician for periodic follow-up evaluation. This evaluation should include assessment of blood pressure, lipid profile, and glucose level for at least yearly. And remember, this is not at the initiation of ADT. This evaluation is on follow-up. At the initiation of ADT, the primary doctor is left to decide. And also there's need for more prospective studies to establish the link between ADT and cardiovascular diseases. Thank you very much.
Thank you, Dr. Madenge. Thank you, thank you.
Our time is well gone. We will take a few questions and comments from the audience to the speakers of the day. So,
kindly keep your question very brief and to the point, and also the responses. Dr. Brugu?
Dr. Njirene, I was glad to hear you saying that before you do chemoradiation, you have to do a completion TRBT, which is a message you have been trying to pass unsuccessfully. So does that lay to rest this myth of hemostatic radiation for bleeding prostate tumor? I mean bladder tumor.
I think so, Daktari. And the issue of the hemostatic radiotherapy, I think for those patients who have had what would be defined as intractable bleeding, but I think the issue has been, if you do not do a complete TURBT, we are going to be in problems. And we know that even if you give that radiotherapy, going back again to do the TURBT again might become an issue. So I think the teaching or what we should be working towards is achieving a near total or complete TURBT. There are those patients who have had multiple resections for bladder tumors, and then we consider giving radiotherapy to the pelvis, but once you give radiotherapy, then we may be precluding this patient from ever getting chemoradiotherapy after that. Thank you.
I have a question to Dr. Kanye. I wanted to find out how many seeds averagely do you implant in the prostate, and how much gram of tissue is covered by one seed?
we usually may put about 50 seeds, but it depends on the size of the prostate. But we remember we said that the maximum is about 50 grams of the prostate. We don't want a bigger prostate because we cannot, it will be toxic as we give that. Now, in the ultrasound guidance machine, we move about a few millimeters, maybe about 5 millimeters staging between the two seeds. Okay.
That means that may knock out so many patients because our prostate tends to be big on account of prostate size, the 50-gram limit.
I'm sorry they will be excluded because if you put in more than about what is required, then you may have toxicity of this iodine. Yeah.
To Dr. Kanyi, thank you for the good work you are doing at the Nairobi Hospital. My question is, do you come across migration of the radioactive seeds into the spouse? And what kind of precautions do you take, or what do you tell the patient after you have inserted the seeds?
Thank you.
And what is the untoward effect when these seeds go into the female?
Thank you. In the presentation, I said that we may have migration of the seeds to the lung, and I said that if it entered the veins, that could happen, but we don't want to put that in the veins. We are just putting it in the prostate as we look at ultrasound. Now, as you do that, you see the seed that will be passing through the urethra and maybe to the spouse. You see, that one would be if it went through the urethra. And I said that as you look at the urethra, you must have about a millimeter or two away from the urethra, so it does not enter in. And we caution them and tell them, not even the wife, but we are looking at children. Because if you have a grandfather like me, and then you have children who are going to play around with you and on your lap, and you have to maintain away from the children because that iodine is still active. So it's active, you can have a child sitting on your lap and then you burn the testes. You are looking at the testes for the child in the future. But other than that, we don't have any migrations because we put and see where they are, and we have to ensure, by ultrasound, we have to ensure that the tumor, the seed is in the prostate and it is fixed. It is not going to migrate.
My concern, Dr. Kanyi, was during ejaculation, definitely the seeds will be squeezed out of, maybe, that's theoretical, squeezed out of the prostate. Do you advise this patient to use condoms, for example? That's where I was heading to.
Yeah, you see, ejaculation is going to come from the various channels from the prostate. It is not getting into the, you see, for those seeds, they must get into the urethra. And they must, and you see, that's why we are saying, we are looking that, if you look at how the seeds are planted, they are not near the urethra, so we are not going to have any. The only problem is which you can get is to the lungs, especially because if they go through the veins, but not out of the prostate.
I think it's important. I mean, Dr. Kanye and I have been doing this now for close to 4 years. And the one thing you will notice when placing the seeds is if you place them in the wrong place, you will see the movement of the seed. And they will probably even come out by the time you have the catheter. And for you to place the seed in the wrong place, sometimes you have to puncture the balloon. There are two balloons. There is the brachial balloon, and there is the urethra, the catheter balloon. And when they come out, we actually look for these seeds with a gamma camera, you look around and you pick the seeds. So we don't even leave them out to go into the environment. These seeds, the radioactivity penetration distance is very small, up to about 1, maximum 2 centimeters. The radiation that we'll get out of it is very little. I've held these seeds with my hands because they're not that intensely dangerous. So you will be radioactive, and you're looking at, by the time you have given 50 seeds, you have put about 100 and something, 20 gray of radioactivity into that patient. But then at the end of it, these seeds remain there, and they have a very short half-life. They tend to disappear very fast. I think it's not as difficult. But I think the next frontier, which we hope should be in Nairobi soon, is the high-dose brachytherapy. And that will probably change how much you can give, and this will enable us to give a higher dose of radioactivity than we're able to do with the low-dose brachytherapy.
Professor Musimbi, how much are we doing towards bringing nivolumab and the like, and we move from sorafenib? And what are the cost implications? And is it worth it?
In the public system, I don't think we are there yet. But like I said, these drugs can be gotten for those who can afford. In Nairobi Hospital, I think it takes about 3 weeks, but there has to be payment upfront. The volumab, I think, is close to $1 million plus deposit. Even in KNH, by the way, you can still get that, but they have to pay upfront close to $1 million before the drug is available. What I said, which might be better for us, is the program for sunitinib. But maybe we can start there as we wait for the other drugs. Yeah.
Dr. Misango, and then Dr. Jogu, as we wind up, brief.
Yes, mine is a very, very brief comment to Professor Musimbi in regard to the chemotherapy of invasive renal cell carcinoma. One of the biggest challenges you normally have in giving medications is, number one, an expensive medication. Number two, a medication with a difficult name. Now, here we have a regimen that actually combines both expensive and difficult name. I'm just curious, if you could just make a comment. What is the motivation behind these companies that come up with those kind of combinations? It's just a general comment that I would like to understand, because you correctly mentioned that the uptake of the medications is very, 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 very low in Kenya. And even if people are going to come up with universal health care, it's going to finish the whole budget if we are going to actually begin using these medications. So what motivates this trend?
Is it industry driven? That's the question. The benefit, is it industry driven?
Before Prof gives her comment, let me just put this out, that the naming of some of this targeted therapy depends on where which pathway is it acting on, and the naming follows that. For example, ipilimumab is a monoclonal antibody, pembrolizumab is a monoclonal antibody, and it is humanized, hence the zoo. So the naming will tell you where something is acting, but it doesn't mean that we choose the sort of the naming. It tells you where it's working. Thank you.
And that is why I put the first cartoon of the different places in the cell cycle development of RCC, because the target is as many pathways as possible to make sure that there is optimum elimination of the tumor cell progression. We also have others which target angiogenesis, that is bevacizumabs. So we have no, I can't tell you why they are named that way, but it is the particular the particular pathways, and making it easier for the clinician to actually associate one drug with a particular line of action. As far as combinations, again, it's the same process. Different pathways of pathogenesis and different blocking places for the drugs. And the effect is better, but the side effects are worse in a way, with very minimal increase in overall survival, because that's what we should actually be measuring. But in oncology, we also look at the progression-free survival. How long does that patient stay on that combination before the disease progresses? It is a plus for us, even if it is 2 months.
Okay. One final one from Dr. Jogu, and then you have Dr. Ikol do a bit of housekeeping.
My question is to Dr. Ngoku, or regards the PSMA PET. We do know issues of false sensitivity, particularly with local tissues like seminovesicles infiltration, whereby you end up with the false positives and false negatives. How do we address these concerns?
Dr. Goku, I hope you're still on.
Yes, I am. A very good question. I think that just belabors the value of MRI in evaluation of the local disease. So there are a few studies that have been done in comparing PSMA PET with MRI, and MRI has come out superior in terms of evaluation of the local disease. So it shouldn't replace the multiparametric MRI as far as the prostate gland, extracapsular disease extension, and seminovesical involvement is concerned. Though having said that, we do see from our experience that patients who have seminovesical involvement on the MRI do have invariably increased uptake in the PSMA PET. I have not seen a case of PSMA PET where the seminovesicles are positive and the MRI was either negative or equivocal. So I think, of course, there are so many studies ongoing and we'll soon have a clearer picture, but I think MRI is still superior in terms of evaluation of the local disease.
Is it type that we considered PSMA MRI? PET MRI rather than PET CT?
Good point. The only issue is if you look at the costs of a PET MRI compared to a PET CT and the value add, it is very low. What people are actually doing is you can do your PET acquisition separately and your MRI acquisition separately and do a fusion. There are softwares available to do fusion compared to just buying a unit of PET MRI. The cost of PET MRI and the value it adds is not worthwhile.
Thank you for a very nice session. I'll ask Dr. Ikol to take over so that we can save a bit on time. And hopefully Professor Mutabilwa will be, it's Professor Gobet, will be online when we resume.
Okay, thank you very much, ladies and gentlemen, for participating in this particular session. Very interesting topics. One announcement, the urological nursing session is going to kick off at Amboseli Hall just after tea. We are going to have a 30-minute tea break. During the tea break, we are going to sing Happy Birthday Cows. I don't know whether we know how to sing Happy Birthday Cows as we celebrate our silver jubilee. The cake cutting, Surgilix has donated or provided a cake to celebrate the 25th jubilee of the Kenya Association of Urological Surgeons. With us here today, we have 3 of our founding members. That is Mr. Maina Kanyi, Dr. Weru Mathu, and Professor Mungai Ngugi. I hope I've given the chronological age. Have I arranged you by age? Okay. So they are going to lead us in the cake cutting at the exhibition center. We hope to be back here. We require to be back here in half an hour's time. Chairman, that's okay? Half an hour's time, so 12 o'clock. Wow. Okay, in half an hour's time, let us be back here, please. Thank you.